morning. What I'm going to present here is a little bit out of the realm of dentistry. This is the future of dental radiology. How many of you are using film right now? Okay, are you using D-speed film or F-speed film? The F-speed film would be Inspire, the D-speed film would be UltraSpeed. Do any of you know the film speed of what you have? Back before digital cameras, we had cameras with film, and the film had an ASA of 100, 200, 400, 800. How many of you can tell me what the film speed is of D-speed film? Anyone know? It isn't on the package, I'll tell you that right now. You can look at the package, it isn't there. F-speed is not even there. The film speed of D-speed film is 19.9. The film speed of F-speed, which is the Inspire, is approximately 56. Okay, does anyone use digital? Okay, can you tell me what the dose per film that you per image that you're getting from the digital? Does anyone know? Huh? Lower than what? Give me a number. 1, 2, 3. Okay. D-speed film is rated at 250 milliroentgens per film. F-speed film is rated for 100 milliroentgens per film. Most digital sensors are rated between 40 and 60 milliroentgens per film. Okay, if let's say an average full mouth series, I'm going to use a whole number, is 20. So if you're using D-speed film, 20 times 250 milliroentgens gives you approximately 5 roentgens of exposure. If you're using the F-speed film, it's 100 times 20, you're giving the patient 2 roentgens of exposure. Let's say we take the average of 50 milliroentgens for a digital, you're giving the patient approximately 1 milliroentgen. How would you like to give the patient 0 milliroentgens? And this is what our presentation is all about. What we have is we've been playing around with optical coherent tomography and also near infrared technology. We have been able to do it on the bench. We have not been able to do it on the patient's mouth yet. We have the hardware, we have the software. The only thing that we're missing is a device that goes into the mouth on this. 1926, G.V. Black would understand dental caries so as to prevent it before irreversible damage. 1800s, we have the development of the X-ray. 1965, ultrasound. 73, computer tomography CT. 77, MRI. And 99, PET. Optical coherence tomography. What we have is you have a detector, you have a splitter, you have a low coherence light source, you have a reference arm, a reference mirror, and a handheld scanner. This shows how it goes into the mouth. This is the preliminary probe that we have. It isn't the probe that we would like to have. With your OCT, what you can do is you can get images of the occlusal surface. You can detect occlusal caries on there. There's 2D OCT and 3D OCT. And you got markers on here, over there, to indicate the caries, and you can see it on the 2D with the pit with the decalcification, and 3D with the pit with the decalcification. Light, we have transmitted light, excuse me, reflected light, scattered light, absorbed light. Your source of light, you have a tissue type, tissue signature, you have an intensity of backscatter light, and echo time delay of light. Today's diagnostic devices give you inaccurate diagnosis, unnecessary invasive procedures, excessive treatment costs. 80% of caries is on the occlusal surface. Your x-rays, conventional x-rays, cannot image the occlusal caries. In general, radiographic interpretation of initial interproximal or occlusal caries is nearly impossible using the current analog or digital radiographs. Immediate attention by inventors and manufacturers is needed to eliminate this obvious void in technology. This is a quote from Gordon Christensen back in 2011. Also another quote, as more advanced approaches become available for managing dental caries as a disease process and maintaining pulp vitality, the need will increase for early and accurate diagnosis and monitoring of dental caries. This is from Ira Lanson, Dental Clinics of North America. Christensen again, in general, radiographic interpretations of initial interproximal occlusal caries is nearly impossible using the current generation of analog and digital radiographs. Okay, we now have an increasing awareness of oral health. We're moving towards minimally invasive dentistry, stronger awareness on prevention. You get better outcomes. Cambria, risk analysis, caries management by risk analysis, assessment. Consortium for Oral Health Related Informatics to establish a database for evidence-based decision-making. This is a typical OCT system. You have your computer, you have your demodulator, you have your detector, your diode source, light splitter, you've got your lens, and you've got your tissue scanning. And the idea is, what we want to do is miniature laser mirrors on each side and on the top. The tooth would go in the middle on here. And this is what the problem is, trying to miniaturize this so that it can be effective. Current diagnostics. X-rays have inadequate resolution for early hidden detection of carious lesions and defects. You cannot image occlusal, limited early proximal lesion, potential harmful radiation. I know at a dental school with our students and stuff like that, where they, shall we say, are not the greatest image takers. You have a lot of cone cuts, missed apices, collimation, and instead of saving radiation, what's happening is the patient is getting exposed more and more. You should also have visual surface detection only. We discourage the use of the Explorer probe and laser fluorescence low specificity. You got to use that with caution. This is near infrared transillumination. Here again is another image of that. There's caries on here. There's the image that we get with OCT. This is the machine that we're going to use. The bottom half contains all the hardware on this. Up on top, you've got your computer pad, and you've got your computer image, and there's an outlet where the probe will go. New imaging technologies and sensitive techniques are required in the early detection of such lesion. That was by Dominic Zero, Contemporary Concepts in Diagnosis of Oral and Dental Disease, Dental Clinics in North America, 2001. Here again, your occlusal caries, your 3D OCT, your 2D OCT. This is a conventional image. Here it's compared with the OCT. It's the OCT. Again, this is a position of the pit, shows 2D, 3D image, caries. Again, Same type of image. Okay, this is the 2D. You got your pit with decalcification. You got undetected decay. It's not seen by the X-ray because you got your X-ray on your left, you got your OCT on the right. This is a lateral view of this. You can see the histology. You can see the OCT. Now, the penetration of the OCT. This is the one downfall of the OCT. You can only penetrate through the first 3 millimeters of tooth on that. You do not get the root surface. The only way that you probably could get the root surface if you need it would be to take a pan on that, a digital pan on this. And this just shows the difference in the resolution. Here again, you've got your normal X-ray, your OCT. Same thing here with the histology. Okay, this is the probe that is used right now. This is not adequate for going in the mouth on this. We have to design something. We've got some ideas that we would like to use on this, and it's just a question of getting enough funding to go ahead with this. All of this, what you're seeing now, is extracted teeth that are in blocks, and they're on the bench top. We cannot do this in the mouth right now. Here again, you got your markers, you got your pits, calcification with caries. Another view. What we had here before was just an introduction to the OCT on this. Today's diagnostic devices. Current diagnostics. X-rays have inadequate resolution for early hidden detection of carious lesions and defects. You cannot image the occlusal. You're limited early interproximal lesion, potential harmful radiation, and you have visual surface detection only. We discourage the Explorer probe, laser fluorescence, low specificity used with caution. What I gave you before was just like a brief overall introduction to OCT and near infrared. Now we'll go into it in more detail. With radiographs, you get inaccurate diagnosis, unnecessary invasive procedures, excessive treatment. 80% of the caries is on the occlusal. This is Christensen again. This is Christensen. This is Lamster. This is the development. Now, the paradigm has shifted to the medical model, which is diagnose early, treat minimally, chemically rather than surgical. We want to reverse decay, minimal removal of tooth surface, and monitor remineralization. Again, over what we had done before. Okay, the nature of carious lesions has changed over the last 50 years with the use of fluorides. Almost all new decay occurs in the occlusal pits and fissures and proximal contact sites. It's difficult to detect in early stages using visual tassel Explorer X-rays. Treatment is shifting from aggressive, which is GV Black's old method, towards minimally invasive or non-surgical techniques. X-rays. You can't image early occlusal caries. Caries is usually deeper than it appears on a radiograph. You have overlap of structural images. You have low resolution. You cannot quantify severity of the carious lesion. Ultrasound, MRI, and PET are not used in dentistry. We have CT volumetric cone beam. It's limited use for gross anatomical imaging. We use it for oral surgery, implants, and orthodontics. NIR imaging, near infrared imaging, has high resolution, survey imaging of coronal tooth macrostructure. It's similar to X-ray. You have no radiation. It's light-based. It's real-time. OCT imaging is high-resolution microstructure cross-sectional focal imaging. It's ideal for dental applications. You get hard and soft tissue. There's no radiation, and it's light-based. It's real time. What you see is what you get. You have an optical biopsy of the tissue. This is the new optical diagnostic imaging platform, NRI, near infrared imaging, and your OCT. Hopefully, if we can develop this, this will replace film and digital, hopefully, with no radiation. Light is transmitted, reflected, scattered, absorbed, biologically compatible wavelength. Light-based platform. Images are formed by capturing light. It's transmitted, reflected, scattered, absorbed. NIRI and OCT utilize the same source of light, 1310 nanometers. NRI is transmitted light, OCT is backscattered light. Imaging. Near infrared transillumination. Visible light is 400 to 700 nanometers. It exhibits strong light scattering character in sound enamel. Scattering decreases exponentially at longer wavelengths, more than 30 times lower in the near infrared. Enamel is virtually transparent in the near infrared with optical attenuation, 1 to 2 orders of magnitude less than visible range. High contrast images are required in the near infrared. Interproximal caries can be imaged by near infrared transillumination of the proximal contact points and by directing light below the crown, just above the CEJ, while imaging the occlusal surface. Occlusal lesions can be imaged by direct light from just above the CEJ towards the occlusal. The visible of scattered structures on strongly specular reflective tooth surfaces can be enhanced by use of cross-polarizers to remove glare. Increasing lesion contrast and lesion area in the near-infrared images corresponds with increasing lesion depth and severity of occlusal caries. Mild fluorosis is shallow in depth with an intact, highly mineralized outer layer, which can be differentiated from deeper caries lesions. Deeper lesions appear with increased contrast. By the time caries lesions are visible on bite wing radiographs, they have typically spread to encompass a large area of dentin, requiring a larger restoration. There are no restrictions on image acquisition, and this method is ideal for monitoring lesions over time. There's no radiation. Images can be acquired from different angles to aid in diagnosis. A combination of images taken from the occlusal and the facial, lingual, and lingual facial aspects can be used to differentiate lesions that are shallow and wrap around the contact point from those that are deeper, centered at the contact point. Pitt and Fisher occlusal stains are not visible in NIRTI images since the organic molecules responsible for pigmentation absorb poorly in the NRI, making it easier to differentiate demineralization versus stain. NIR-TI, 1300 nanometers, highest contrast for proximal lesions, 1460 nanometers, highest contrast for occlusal lesions. Your best contrast is hydrated best for NRI, TI, and OCT. Drying is best for reflection. Contrast of NIR-TI occlusal lesions can be correlated with lesion severity. 1460 nanometers, higher water absorption and best for reference reflectance with better contrast. Also best for imaging around composites due to lower water contact or composites than surrounding tooth structure. X-rays do not measure lesion depth and not indicated for regular monitoring due to continual radiation exposure. Near-infrared imaging has no radiation restrictions on image acquisition. It's ideal for monitoring lesions over time. Images can be acquired from multiple angles to aid in diagnosis, aid in lesion location and depth. A significant difference exists in the mean contrast between the lesions confined to enamel and the deeper dentin lesions. This is important to make a treatment decision, whether surgical or more conservative chemical intervention. Bite wing radiographs do not show the depth or activity of the lesion. This is the near infrared. This is what we're hoping to do, some sort of device like this, where you have your mirrors, which are in the blue around the B, which is the tooth. C is your handpiece, and this is for the interproximal, the other one's for the occlusal. And this is premolar near-infrared imaging of natural caries lesions for multiple view. You got your NRI occlusal, your buccolingual, and your X-ray. You do not see the lesion on the X-ray. Here again, caries. Your incisors, you can see the lines. Here is your caries, your occlusal caries. Again, X-ray versus OCT. It's non-invasive, non-ionizing radiation. It's analogous to ultrasound B. Depth resolved microimaging CT slices. 2D and 3D capabilities. You get real-time images. Optical biopsy, like I said, it's 3 millimeters of depth. Hopefully, maybe in the future we can get a little more, but right now it's only 3. Quantitative and qualitative information. High sensitivity and specificity. Images through water, saliva, and plaque. Here again, it shows you the depth of resolution of the different types of things. Here is our undetected occlusal caries showing up with the OCT. Light backscatter, source of light 1310 nanometers, tissue type, tissue signatures, intensity of backscattered light, echo time, delay of light. Here's the setup for the OCT, which I showed you before. Our probe, machine. This is based, this is Petra Wilder Smith out at University of California, Irvine, doing this. This is what the markers show. Again, lateral view with histology. Again. NRI replaces approximately 70% of dental X-ray imaging. OCT provides the necessary imaging to practice evidence-based, minimally invasive dentistry. Clinicians hopefully will have, for the first time, the scientific basis for early diagnosis, treatment, and monitoring. This again is quotes. These are acknowledgments for some of these things. Daniel Fried, Dr. Haggai Shemesh, Dr. Petra Wilder Smith. Thank you. I also want to introduce some of my colleagues from NYU and also from the Ukraine. Dr. Igor Shemitra is here from the Ukraine.